typical cases. So let's see what we have here. Here is an example of classic lobular neoplasia. So the way I identify lobular neoplasia, low power, I always scan around, you know, sometimes, especially for a typical lobular hyperplasia, can be difficult to find it, right? So I use always as a reference the normal acini, and I expect that even in, you know, normal acini that are very small, I still can see a lumen in the center. So for even at this low power magnification, I'm sure you can all see the lumen inside these acini. And so I scan around, and when I see an acinus that is full of cells and doesn't have that central lumen, I will stop and see if it could be lobular neoplasia. Again, at low power like this, of course, these are pretty obvious, right? But I want to show you this area because you can see how at this magnification, these cells are not as cohesive as these other cells are, right? So these stick together. There is a lumen in the center. The lumen is filled here, but the cells are not sticking together. You see some clearing in between the nuclei that you wouldn't expect if it was a ductal proliferation. So that's, to me, a nice, you know, useful feature to find the minute foci of lobular neoplasia on a scanning, you know, when I scan the slide at low power, I cannot go to high magnification in every case, right? And then to confirm the diagnosis, one goes to higher magnification and looks for the cell morphology we just discussed. Here are the fried egg cells that you know, are retracting, and you can see clearly these you know, tendrils in between the cells and this stretched cytoplasm at the periphery, the spidery look I was telling you before, that is quite characteristic. And then again, we have the myepithelial nuclei that are even in the middle of the proliferation. There is one myepithelial cell nucleus. How do we recognize it? It's smaller, it's more hyperchromatic, and probably either this one is a ductal cell, a residual ductal cell, so it could be a myepithelial nucleus. Maybe it's a residual ductal cell right there. But all these, again, you find 3 cell types. Here is another cell with that vertical orientation, another nucleus, probably a myepithelial cells. So I always look for myepithelial cells in the middle of classic of this proliferation to support the diagnosis of lobular neoplasia, in contrast to a case of solid, you know, proliferation of with ductal nature. So here there are no other specific findings, just a typical morphology. Here is another case. Yes. These I would call it classic LCIS. You know, because all the acini are involved and there is expansion of all the acini. That's another thing. What is expansion? Again, always use the normal acini as a reference. At least that's what I do. And there is always a normal acinus nearby I can use. And these look enlarged, right? A little expanded, but they're not at the level of florid LCIS, even though the cells are the same. So there is expansion compared to the normal acini that we see in the background. So filling and expansion of the acini in more than 50% of the acini of the terminal ductal lobular units, I would call this classic LCIS. Here is a partial involvement, maybe, oh, actually, I didn't realize. So there is an area here where we still see probably a central lumen. Maybe there are some residual ductal cells in the center. Whoops. Hard Yeah, they still look like lobular to me. I don't know exactly. Huh? Yeah, these ones have a more ductile look, more hyperchromatic nuclei. Here, there may be even collagenous spherulosis. I don't know what's this, and maybe this is also collagenous spherulosis. I don't know. There are myoepithelial cells up here. There is no question. This is classic lobular neoplasia. Any questions about this case? No, it's pretty classic. You know, I think they had a little bit of cytoplasm. Usually we don't say type A or type B. I think they are a little bit larger than usual. Yes, the nuclei are more open. They have more open chromatin. So yes, I would say type B cells. Now, it was interesting to see that the terminology used in the WHO classification was first introduced by Hagensen ages ago, 98, a long time ago. Yeah, and then kind of abandoned. Nobody talked anymore about type A or type B cells, but they kind of revived the use of this terminology. And I think it makes sense, but it's not reported. We just report this classic lobular neoplasia, and that's it. So do you use type A, type B? No.
The comment was only because of the border between type B and pleomorphic.
Sorry? Yeah, it's useful in those cases. I think it has some utility, and it's good to recognize these two variants, and especially not to call these in comparison with the type A cells, not to call these, you know, florid, or think that this is more pleomorphic. These are normal cells in classic lobular neoplasia. Yeah, I wanted to show, I don't know, this is another case. I have just examples of classic lobular neoplasia. Let me see. Here is another area. There is a little bit of ADH here that is somewhat cohesive. The cells are atypical. Here, some suggestion of atypia, a little bit of this columnar cell change Dr. Collins illustrated yesterday with micropapillae that are starting to merge and almost want to form an arch. The nuclear features, if you look at the nuclear features of these cells right here, they're nice and round, and they have a very small inconspicuous nuclei. These are ductal cells, so nicely cohesive. And then right next to it, there is a focus that has lobular neoplasia. And the nuclei look exactly the same, at least to me. They look really similar. It's really a nice, you know, in these cases where you have ADH, low-grade DCIS, tubular carcinoma, ALH, classic LCIS, flat epithelial atypia. It's really a whole family of lesions that all look the same in the nucleus. They're all related, but then a different extent and different also in cell morphologies, like, you know, a big Italian family with many cousins. That's what I say sometimes, yes. They all look the same, right, in a big Italian family, or any big family. I have another case with tubular carcinoma, but I will not show it. Oh, here is an interesting case. So classic, let's see what we have here. We have, maybe you guys can render the diagnosis. These are not challenging cases. A fibroadenoma done for calcifications. This actually illustrates also the point that Dr. Collins made yesterday about calcification kind of scratching the tissue across. Here is a focus. So, you know, normally in fibroadenoma, we find especially in the sclerotic ones, we find just a layer of cells, you know, residual ductal cells, but here there is a little bit of expansion. So again, an example of a typical lobular hyperplasia, probably I would call this. It's not very extensive. It's hard to classify it in a fibroadenoma, right? It's not the typical context, but it's involving a fibroadenoma, probably in an elderly lady. And came to detection incidentally because of calcifications, and the findings is completely benign. We're not going to excise this lesion at all. It remains benign here. Yes. Any questions about this? No. What do you do for classic lobular neoplasia? How many excise? Is it excised at your institution? No? Nobody excises it? So please raise your hand if you excise it. How often do you find cancer? How often do you find carcinoma? Huh? In cases of with the classic lobular neoplasia and a core biopsy, do you find cancer in the excision? In the majority? Oh, wow. Okay. But my experience is different. So I mean, it all depends on the radiologist.
I think it's very much exactly.
Huh?
Exactly. Probably it's the way to explain.
Excited?
No, we do not.
Yeah.
If we have a laboratory inside to.
I think really, I always say we are as good as the material we receive. We can render the diagnosis only if we have some diagnostic findings. So I always worry, yeah, and I always worry, you know, about how good are the radiologists sometimes. So what do we have here? Another example of lobular neoplasia. This is an interesting case. It's a quite florid. I shouldn't use the term florid. Yeah, it's extensive because it can be more misleading. What do you think is the underlying lesion here? Is there an underlying lesion at all? No? Oops. Maybe it's microglandular adenosis with lobular neoplasia. I hope not. But I didn't call it as such. So no, it looks like it could be a fibroadenoma, but is it really a typical fibroadenoma? It looks like a hamartoma, Laura. So this is a hamartoma. There is benign breast parenchyma, or at least the structures look like benign. There is a lot of fat, but this fat is encapsulated, right? It's circumscribed. There seems to be a capsule all around. And inside these lesions, this benign breast parenchyma that is found in the hamartoma, we have areas of lobular neoplasia. Hamartomas are, you know, or choristomas, as Dr. Rosen would like to call them. They are, you know, normal. You find the normal structures of the breast or any organ, but in an abnormal arrangement, haphazard arrangement, maybe malformation. And they can be pretty large. This is not a small lesion. And they also can be subject to the same alterations that we find in the breast epithelium or in the stroma. So anything can arise in a hamartoma. No, no, definitely not. You know, for the diagnosis of hamartoma, we need a complete excision. You need to see the capsule, the circumscription, this array of the glands and, you know, the stroma, the fat. You can't do all that in a core biopsy. The radiologist may, you know, suggest it. And actually, we don't see very often hamartomas. We don't get them. Do you get them? Yeah. Yeah? Do you render the diagnosis on core?
No, but like you say, I think sometimes the radiologist lays the differential diagnostic consideration. And I've certainly seen situations where I thought it probably is a correlate for a hematoma. And so, maybe I'm just descriptive there and say in the appropriate clinical and radiologic circumstances, it's consistent with, yeah.
Yeah. Thank you. It's also a very local preference. I remember I trained in one institution. We had a hamartomatous lesion a month. It was a very common diagnosis. I came to Memorial, and because, in the tradition, Dr. Rosen didn't render the diagnosis of hamartoma very easily. Nobody diagnoses hamartomas. So they're very unusual. In some places, very common, in some other places. There are local preferences in diagnosis. I don't know if you have, here is another case. Again, anyone wants to describe? There is a background of what? It looks like adenosis. Dr. Collins showed a case very similar, I think, yesterday, with all these big expanded areas of adenosis here and there. Some, and then in some other areas, so there is this proliferation. What do you think about this one? Ductal or lobular? Lobular, definitive. So why is it, what makes it so lobular? I guess, excuse me? Oh, yeah, I need to focus.
There's fried eggs,
Fried eggs.
loads of them.
Yes. All over the place, right? Some decision, but it's a solid proliferation, right? So here is an ecadherin stain. Let's say I want to demonstrate it's a lobular proliferation. I do ecadherin, and that focus, where did it go? It's right here. How do you interpret this ecadherin?
It's attenuated. It's not
Right?
strong
Yeah.
everywhere.
So it's consistent with lobular neoplasia. You're not concerned. I'm not concerned either. And again, I think that there are residual cells, maybe myoepithelial cells, some positivity. Remember what I was saying before, to look for areas where there are two cells adjacent to one another. Here, for example, in this spot, there are 4 cells in, there is no staining in between these cells. I have, for this case, I don't have beta-catenin because I rarely do beta-catenin, but I have a P120 that shows that pattern, nice cytoplasmic membranous staining all throughout the lesion. And then, the area that I wanted to show you is somewhere here. And in my experience, as I was saying before to someone, I prefer to do ecadherin for in situ lesions and P120 for invasive, because sometimes it can be difficult to interpret or see the P120 positive cells in an in situ proliferation because they are less conspicuous. It's easier to see a negative stain in this setting, but here there is a beautiful cytoplasmic staining, and the residual ductal cells are still positive. There are a few down here, for example. Just for your interest, there is another stain that I oftentimes do, I like very much, is a cocktail of antibodies that includes P63 and then CK56, CK514, the basal cytokeratins, and CK718, the luminal cytokeratins. And here is in the same area, and illustrates how this is a focus where we have, very different cell types. They are the my epithelial cells would be at the periphery. Here are the nuclei of the brown nuclei stained with P63 all around the acini, but in these areas are almost like more raised up, more towards the center of the cell, the proliferation. And then there are a lot of these brown cells that are probably UDH cells. And then we have our fried egg cells. So this is a case, that are only red. They stand out compared to the UDH cells because then the UDH is brown, the lobular cells are only red, and actually it brings out even more the fried egg morphology. So that's another stain that can be useful, especially like in this area. And, you see this, the rounding up of the cells really stands out with this staining. So I'm becoming more proficient in the use of this staining also for the diagnosis of lobular neoplasia. It does correlate. And actually there were, in the past, I think Dr. Tavassoli had reported how CK18 was useful, was a marker of lobular neoplasia. It was essentially doing the same thing. There is CK18 in this cocktail. It was just staining the cells and highlighting the rounded appearance of the staining was very periductal, the fried egg morphology was coming up. It's, you can get it with any keratin type. Here I have a bunch of cases all stuck together. Let's see what they are. So probably all the same entity. Anyone who wants to describe this case once I show it? All right, here is the tissue. It's a core biopsy. Any volunteers? Excellent. Who is the volunteer? Oh, I heard I thought that. Otherwise, I know a few names I can call. I can call. Volunteer. You have been volunteer. So what about this case? Is it in focus? So this biopsy was done for calcification. And I'll give you more to see. I hope it's in focus.
It looks like classic lobular carcinoma in situ in an adenosis.
In adenosis?
Hmm?
There is this entity we were discussing.
Collagenous spherulosis.
Collagenous spherulosis. Excellent. So I'm glad it's quite characteristic. There is the cord sign right across here and here and here. The basement membrane has kind of collapsed. We have, these spaces are not true cribriform spaces. They're filled of material and, this delicate material. So it's a beautiful, it's a nice case that was actually mass forming probably also because it looks like there is a discrete nodule in this area. Many times I've seen cases where a case like this was diagnosed as low-grade DCIS in the core with calcifications, and then they do the excision and they say, well, there is nothing left. There is only LCIS left. There is, the DCIS was removed entirely by the core biopsy. That's the typical story. And so sometimes the clinician will say, well, does this patient need radiation? And you measure the DCIS in the core biopsy. So we end up, going back and looking at the case, and we recognize that there has never been DCIS in the case. And, yes.
I have a comment. How frequent are these cases of collagenous fluorosis?
Actually,
You have shown us a large series of cases. So I'm thinking about how many I missed in my report.
I think they are more frequent than one can think. It's rare to have this much, volume of LCIS and collagenous spherulosis kind of forming, this is probably a 0.5 centimeter lesion, right? But they are common, and I've seen a number of cases misdiagnosed as DCIS. That's my experience.
Yeah, I would say. Yeah, also, I would agree it's pretty common to find collagenous sferulosis and LCIS together in a case. Sometimes as an incidental finding in you know, a biopsy or excision for something else. I actually had a reduction mammoplasty a few weeks ago that had tons of LCIS and collagenous sferulosis. So I would say it's fairly common.
We will look carefully in the future, okay? At least me.
Yeah. This is the same area, a little bit, you know, damaged, I guess, at some point. But and you can see this is an ecadherin stain, and you know, if one is not careful, ecadherin could be misleading in this case because there is a lot of positivity, as we discussed already, and even in this area, it seems to almost highlight the cell membrane of these cells, right? Except that focally you recognize they are fried egg cells that touch each other, one another, and they're negative for ecadherin. Here is that central pattern of staining with the you know, secondary to the myoepithelial hyperplasia. So it is not infrequent that these lesions at a quick glance can, you know, low power, oh, DCIS, low-grade DCIS, let's do ER. ER is positive. Next case. So it's good to see different, I'll show you different morphologies, different cases. Here is a case, the same case with the ADH5, I think, with the, you know, that antibody cocktail that I like very much. And it's right here. You can tell how many myoepithelial cells are present in this focus by the number of brown nuclei that are staining. And, you know, there is a lot of this hyperplasia of the myoepithelial cells that is occurring. Oh, flip to the condenser. Thank you. Yeah. And again, all these floating edges of collagenous sferulosis that are. So if you see that in a low-grade DCIS, that's not a low-grade DCIS.
The floating thing
Yeah.
within the lumina, it's something that I will remember.
I'll show you a few other cases. This one is, you may recognize, actually. So you will never forget collagenous sferulosis and LCIS. Now, so here is, here is another big collagenous sferulosis with lobular neoplasia. Yeah, even this one is, you know, similar, and a discrete little nodule that, again, could be easily interpreted as low-grade, as a DCIS entirely excised by the core needle biopsy. So yet another case. This one has a little bit of nuclear enlargement, a little bit more, you know, pleomorphic, I don't know, but definitely focally the nuclei are a bit enlarged. So would this be enough for pleomorphic LCIS? It's a judgment call. Would you call it pleomorphic, Laura? Yeah. So in this focus, there is some focal pleomorphic LCIS together with classic LCIS in collagenous sferulosis. A unique case because it's a very uncommon combination.
Yeah. Do you want to just show them the basement membrane again, though?
The basement membrane?
You know, in the collagenous sferulosis.
Oh, yeah. There is right here. The transecting basement membrane. It's very refractile all around, but there it's, you know, cuts across the duct. And I have also, yeah, in this one, I guess I didn't have sorry, I didn't have ADH5 yet. Not the case because I did only P63, 484. Then, yeah, this is the area. This actually has the advantage compared to the ADH5 stain, the triple stain I showed you before. It really nicely highlights how the orientation of the myoepithelial cells changes in combination with lobular neoplasia. The nuclei of the myoepithelial cells are oriented vertically, and they really grow inside, the cells grow inside together with the lobular neoplasia. It's pretty neat. And I'm not sure how that happens, but there is a lot of myoepithelial hyperplasia in this case. You can see that, and that correlates with the collagenous spherulosis and also with the positivity for icadirin all throughout this proliferation. So we have discovered the new orientation of the myoepithelial cells. And maybe I'll stop with the switch. Okay, how about this case? This is another 62-year-old. She has ipsilateral DCIS, and she had, I don't know, is this a core biopsy? Or yeah, it looks like it's a core biopsy. So from another region, maybe there were calcifications. There must have been calcifications. So I'll show you around a little bit. There isn't much. Usually it's quite inconspicuous. You know, the lobular neoplasia can be very inconspicuous, but here we find benign appearing epithelium, here calcifications, more calcs. What do you think about those areas? Is there lobular neoplasia here? At low power, we see these acini are filled, right? What do you think? Is it lobular or not? Sorry? Myepithelial, excellent. Mimicking lobular neoplasia, terrific. So this is a focus of myoepithelial hyperplasia. Why did you say myoepithelial proliferation? All right, well, you got it. So I hope I can demonstrate that with the P63 stain. It's a very focal finding. Yeah, it's really very focal, seems to have been almost wiped out. But yeah, there is myoepithelial proliferation, myoepithelial hyperplasia in this case, but no lobular neoplasia. Here is a good example. It's a demonstration of how, you know, sometimes the myoepithelial cells do mimic can mimic in some ways lobular neoplasia. This is an elderly patient. Sometimes we see that after radiotherapy, myoepithelial hyperplasia without lobular neoplasia, or in patients post-neoadjuvant chemotherapy. I don't know if this patient had been treated. I don't think so. That doesn't say. She had not been treated yet. But, you know, there is a lot of myoepithelial hyperplasia. Could pick up. Excellent description. Thank you.
they have a sort of floral
Look,
aspect. So like,
like
Italy-
in adenomyopithelioma,
No,
maybe.
that's the morphology. It recalls me of a flower. Obviously,
flower.
coi petali, no? No.
Yes, you think there is a flowery appearance here? Yeah, it looks like
I'm romantic, yes.
You know, that's an interesting thing.
I
There
have,
is
I have
also a
a
lot,
couple of cases were so floral. I will send you the pictures.
yeah,
So it's like a
There
flower
is-
or
there is a lot. Yeah, there is a lot of collagen, of basement membrane here. A little bit too much basement membrane to be a lobular neoplasia. So nice. So these shouldn't be mistaken. So we move on to another. Let's see here. Let's see what's here. What about this one? Is it in focus? Oh, good. This one I have no clinical history, but you know, it's an excision. Looks like the patient had a biopsy. And what do you think? Anyone wants to describe? There is obviously something there, but here is one area. Excellent. They are too good. We have to, I'm sending my cases here to diagnose. And actually, I don't know what's in this space, if there is a collagenous spherulosis here or not. It looks like, I must say it's an uncommon finding in Florida CIS. You know, it could be, yes. There would have to be myopithelial cells. So this is the one case where I don't have myopithelial stains. So we'll never find out. But the important thing is that there is no cribriform. There are no glandular spaces in this case. And you always have to consider the possibility of florid LCIS or pleomorphic LCIS when the proliferation is entirely solid. There are no glands anywhere, because these cases also can, I mean, they have been very easily diagnosed here, but can be, they are not uncommonly mistaken as DCIS once again. And I've seen a number of cases that, you know, were diagnosed as DCIS, solid type, low nuclear grade, next case. So this is, there is decision when you find a solid proliferation like this that is solid throughout. Do, you know, if you have any questions, do the immunohistochemical stains for icadirin. Let's see what's going on here. Some cells very focally have a little bit more cytoplasm, right? It's, you know, almost like a intracytoplasmic mucin. And then there are some very bizarre looking cells growing here. So far, I wouldn't change the diagnosis of florid LCIS based on these bizarre cells. I need more to call it pleomorphic. Again, it's again a judgment call. I think in this case, there may be other areas that are more pleomorphic. So I'm going to, maybe this case, I'm going to, you know, move it out and see if I can find them. So sometimes also in this florid LCIS, you may find this dropout of the cells with a histiocyte in the middle. And this almost mimics, you know, a glandular configuration, but it's not, and should not be interpreted as ductal because of that. It's quite common as well. Here there are a few scattered larger nuclei again. So this case wants to become pleomorphic, and from a molecular standpoint, actually it has been shown that pleomorphic apocrine LCIS and florid LCIS are very closely related. Here is another area where some of the nuclei become a little larger. Here is a focus of a residual acinus that mimics a focus of ADH perhaps. And then there is an area that is dotted here where clearly we have a tiny focus of invasion, in this case, reactive stroma. I think in this case there was more invasion as well. I don't remember the details, but there is a tiny focus of invasion right there. Once you have an invasive carcinoma, it doesn't really matter too much where it's classic or pleomorphic, because they're all invasive. But it matters to recognize that it's lobular, perhaps, because of the lobular lesions tend to grow more, metastasize to different sites, the leptomeninges instead of the brain, the pleural versus the lung, and so forth. Here is another case, another core biopsy. The patient is 78-year-old and has a suspicious right breast mass with calcification and a history of contralateral BCIS. So many times, special variants of lobular neoplasia, as well as apocrine lesions in general, tend to occur in elderly patients. Here is the core biopsy showing, anyone wants to describe this case? Can you see it? Yeah, very apocrine, correct. In terms of nuclear atypia, it's monotonous. So monotonous meaning not pleomorphic. They are, again, scattered, binucleate cells, focally trinucleate cells, perhaps, with larger nuclei. Here, this particular focus has a more pleomorphic appearance, but, it's one area. How do you report these cases, Laura? Oh, sorry.
I tend to, so for something like this, I think you would say that it's florid LCIS with, I think I said before, I sometimes say with focal features of pleomorphic LCIS when there are some nuclear atypia, but it's not enough to tip me, or nuclear pleomorphism, but it's not enough to tip me over to PLCIS.
I agree. We also call these lesions florid and with focal nuclear pleomorphism. And I don't have.
And do you mention apocrine differentiation, or it's just?
We may mention that. Yeah, not always.
It has no clinical relevance.
Yeah, it has no clinical relevance, but it can help. Some of the information we pathologists provide is more for the use of another pathologist who will get the case later on to kind of say, this is what I saw, and here is another case. This, let's see. So this is another case where I don't know the details of why this was done, and how much florid, let's say this was in a core biopsy, it seems to be in an excision specimen, but let's say we found this in the core biopsy. How much florid LCIS should we, areas with florid, with massive acinar expansion, should we have to call it florid and prompt excision? And there is no information about that, right? I think I would call this florid LCIS and classic LCIS. There are at least 2 or 3 or even 4 or 5 acini that are massively expanded by this very monotonous proliferation of lobular cells. So if I had this in a core, I would say florid LCIS, maybe very similar to the case before with apocrine morphology, but in some other areas is involving sclerosing adenosis. So it's not as expanded, but would need to come out as well. And I mentioned before that mitosis are uncommon in classic lobular neoplasia. We do see them in these variants, not infrequently. It's easy to find. So another florid LCIS with apocrine morphology, some nuclear pleomorphism, no invasion. This is uncommon. I generally do myophilia. No, I do a positive stain to rule out the possibility of invasion. Yes.
So do you count across to see if you have 40 cells across the space? I mean, when something's like that on the threshold like that, you just
No.
say, okay.
It looks very expanded to me. I mean, I'm not that compulsive, but do you?
No, but I think that one is kind of on the border. I mean, it looks funny enough, but I think I would also say that it needs to come out.
Yeah, no,
Most of them are not that
oh, this is the other one. Yeah. I think there is also some nuclear atypia here that would justify in a core biopsy, would definitely justify an excision. To me, in a core, I wouldn't hesitate to get this thing out, regardless of whether there are 40 cells across or not. And in the United States, we have this saying, when in doubt, get it out. And I apply it a lot. If I have any questions that I cannot resolve, I'll take it out. Here is another case. Again, we're looking at this spectrum of lesions here. Another case where a biopsy must have been done. How about this one? This looks, it has big nuclei even at low power, right? Actually, that's, that's not a diagnostic feature, but that is something I use in practice. I look at this 4x magnification. And if the nuclei are so big that I can see them and they don't look uniform and regular, I think, oh, this is probably pleomorphic, right? It looks really, really ugly. And then we go to higher magnification and look for the nuclear atypia. It's very diseasive. Can you see it? It's actually less atypical at low power, at high magnification than it looked, but I think maybe I'm not in the right spot. Right here, there is a, here it's really pretty ugly. So I would call this, I would say, pleomorphic, right? This is there. Yes.
It's difficult to me to understand why AJCC doesn't classify this lesion as in situ. Why?
It's difficult for me too, you should ask. Yeah, I don't know. Because there is a...
It's identical from in situ.
We agree with you. I think I'm sure I can speak with also for Laura. Yeah, we were shocked when they removed the LCIS as an in situ, from the staging system, and they stated, oh, it's benign. It's a benign lesion. Well, it doesn't look benign in this particular case. I don't see invasion though in this particular. I'm trying to find if there is invasion. And many times here there is also a little bit of this feature of the massive expansion of the acini with very little intervening stroma between, the expanded acini. You can find it also in florid LCIS, but, here is the case of florid without invasion. At least, yes. And do I? It's not my job to suggest how a patient should be treated. So no, I don't. I go with the management that is in use at our institution. We follow these patients. They're all listed in a, in a registry, and they see what happens to them. Some of them, we don't give radiotherapy, and some of them have recurred with either the same lesion, with microinvasion, with invasive lobular carcinoma. That's why I always try to find invasion, because I know most likely it's going to be there, and I do the stains because that changes the whole thing. Yeah, do you radiate these cases?
Some of our radiation therapists do.
Yeah, at our institution, we're very, consistent with the management. So this thing of some people do and some people don't, in general, is not working. But we do discuss these cases at the tumor board, and the conclusion is no radiation. Here is another case with more apocrine morphology, massive necrosis, expansion. Here is another case that doesn't look like a pleomorphic, but more like a florid with a lot of apocrine change, although this area here looks like more pleomorphic. So the two, as I said in my presentation, can coexist, and a lot of necrosis. Now, I want to point out one thing here, how when the tumor cells necrose in these cases, generally they fall apart more like round cells. I don't know if you agree with me. At the interface with the area of necrosis, the cells seem to be rounding up and then fall down, they die as round, almost single cells. There is almost like an irregular outline in these cases, right? Yeah, sometimes that is a helpful feature in establishing, is it a ductal or a lobular? Not always it works, but in general, they reveal themselves definitively, even without the use of immunohistochemistry. You see they are all nice and round, plasmacytoid, ovoid in shape. I'll show you another case. I can ask your opinion on this. Here is another case. Where there is an in situ carcinoma. What do you think? It was biopsied, so this is the excision specimen. And there is invasion. What do you think about this case? So it looks like it could be lobular, right? Huh?
It does look fried egg-like.
Yeah, it looks fried egg. It has this smooth outline. So at the right here, it's not, the cells are not dying like a lobular cells would do, right? They have this smooth edge that there is no polarity though, and just these flattened cells. So it looks lobular, but it has something funny. So I did the immunohistochemical stains on this case. And there is a focus of invasion. What do you think about the invasive? Lob. So it looks like a florid LCIS with invasive lobular. Here is Edi Brogi. So icadirin is positive. What do you think? Including in the invasive carcinoma, right? And icadirin is beautifully highlighting also the invasive area. But is the in situ carcinoma ductal or lobular? You think it's ductal? In this area, right? We should look at the corresponding protoformation. I have P120. I'll show you P120. That is that focus. Here it looks polarized and it has a smooth edge, right? Okay. Anyone wants to bet what the P120 will show? And give us an interpret. Huh? You're both right. This is a case that strangely stains both, this is P120. There is a lot of membrane staining, but there is also a lot of cytoplasmic staining. And in some areas, you can almost see the two very distinct. Here there is membrane staining, here is cytoplasmic staining. So how to interpret a case like this? Is it ductal or lobular? Let's see that focus where there was cell polarity, if it's still there, I don't know. It's an interesting dilemma. The invasive is also staining the same way. It's mostly ductal. So there is always this question, do you use icadirin or P120 to diagnose the morphology of the invasive carcinoma? It's of no practical utility to know. I would have diagnosed this as invasive lobular in that previous H&E slide. That's what it looks like. Now, is this a truly mixed ductal and lobular carcinoma? Definitely looks like some of the cells are polarized, and icadirin, actually P120, has this U-shaped staining, not staining the membrane on the side facing the lumen, which is, the appropriate staining pattern. But then there are some cells with cytoplasmic positivity. So it could be a truly mixed ductal and lobular. Could be called florid with invasive lobular, or could be called ductal with lobular features. Sometimes, this tumor is not really fully declaring itself. And you were both right. It was positive for both.
Oh, wonderful.
I think we
So-
called it, I have it here listed as ductal, mimicking lobular, and with the border with necrosis.
But the infiltrative one was lobular. I mean,
Huh?
you signed out as lobular.
Lobular, yeah.
So morphology still wins over.
Looks lobular in the morphology. Let me show you some other cases. I don't know. Do we have time, or are we done? We are done. No, I don't want to insist.
We are all enthusiastic about this.
You do? Yeah, okay. I'll show you one more case. I have it in the lobular lesion. And this is an invasive tumor. We're in the breast. So an invasive, there is benign breast parenchyma, there is invasion right here. What do you think about? Huh? Pleomorphic. We have a vote for pleomorphic. Very pleomorphic, right? These cells are growing, they're diseasive cells, they're definitely, it could be a pleomorphic. And, you know, this case was initially diagnosed as invasive carcinoma, favor pleomorphic. It's triple negative. It turns out that this patient, turns out had another lesion, a paraspinal lesion, which was biopsied. And it was actually, I don't remember the details, but there was a question whether it was metastatic, right? Well, in the cytology specimen, it was biopsied by FNA. In the cytology specimen, the nuclear features were more evident. And if you look, the nuclei look like a little bit clock face, as we say. You know, there is a central nucleus and then the chromatin at the periphery with a distribution like the clock face of a cell. So this is a case of, you know, a plasmacytic neoplasm that, because it's single cells, you know, and it was in the breast and it was triple negative, was thought to be an invasive pleomorphic high-grade lobular carcinoma. And this is, you know, thankfully we caught it thanks to the biopsy of the paraspinal lesion that was probably the primary, and this was the metastasis, not a reverse. And the patient had already received one cycle of chemo, as I mentioned. You know, I was discussing this case with someone else the other day, and but the chemo, you know, when we spoke with the clinician, was like, okay, that's fine, it's okay. And they didn't seem to mind too much that one cycle of chemo was okay. So, and then they transferred her to a hematology service. This is CD138, and it stains. It was, you know, once we realized it was not, it looked like a plasmacytic neoplasm, we did the appropriate stains and we amended the report, and it was cytokeratin negative. So again, the point is being not everything that is in the breast is a breast carcinoma. Sometimes there are other lesions that can mimic it. And it's easy to fall, you know, in the mistake. But thank you very much.